Give a little bit of overview on what Jordan and I are going to talk about today. First, we're going to review the incidence and the risk factors for memory and learning problems in BMT patients. Second, to identify signs of specific learning problems. Third, to start the discussion of neuropsychological testing, and also to learn process for school assistance and accommodations. To give a little bit of background, learning and memory problems can impede educational progress, as many of us already know just from the general literature. And educational progress can also be affected by treatment for cancer during adolescence and childhood, and I'll talk about that quite a bit. But most importantly to think about is damage to the brain and or the interruption of its development, the brain's development, can cause neurocognitive problems. And that includes things such as ability to learn, to remember, and to also to do processing. When you think about potential risk factors for educational problems that are associated with bone marrow transplant, I have a list here that I'll go through a little bit more in detail. But we need to think about the prior diagnosis and treatment if there was cancer before the bone marrow transplant. And specifically associated with the bone marrow transplant, what is the type of preparatory regimen that was used? What was the type of transplant? What was the age at transplant? And also, what was the neurocognitive status prior to this transplant? So kind of keep this all in mind, and I'm going to talk about all of this in a lot more detail. When you think about prior diagnosis of cancer, people might have prior educational problems even before the time of diagnosis. So, for example, there might be socioeconomic issues, there might be a previous family history of cognitive problems, that sort of thing that you need to keep in mind. But actually, during the treatment, the prolonged absence from school, as well as the reduced energy level, which we very often see in kids who are diagnosed with cancer, can cause a problem and can impede this educational progress. And also the type of cancer therapy, and I'll talk about that in a little bit as well. The diagnosis of cancer at a very young age. What the theory is that if the brain's already been developed at the time of diagnosis, that part which is developed actually stays intact, but it's those parts of the development that haven't occurred yet are the ones that become most affected. And also certain kind of cancer diagnoses. Leukemias, generally speaking, have quite a bit of treatment that is focused right on the central nervous system, both radiation and intrathecal chemotherapies as well. And so you're directly affecting the brain. And then when you also think about brain tumors, that obviously the treatment is affecting directly the brain, but you also have to think about the location of the tumor as well as any sort of surgery that goes along with that treatment. Also, when you're thinking of prior cancer treatment, you have to think about other things as well, too. There are certain types of platinum drugs that can affect the hearing, which can also affect an individual's ability to learn. Cisplatin and carboplatin are the two major chemotherapy culprits, so to speak. But also radiation to the ear or to the infratemporal region is also something that needs to be taken into consideration. We also need to think about vision and how important that is in education. And any sort of solid tumors in particular, where the eye or the orbit or the face is affected, any type of radiation to the orbit may also cause vision problems, which may impact learning abilities as well. And as I mentioned before, cancer treatment that is directed to the brain and or the central nervous system is of particular concern, and I'm going to talk about that a little bit right now. Intrathecal or IT is a way that chemotherapy is injected directly into the spinal fluid. This is most often seen with leukemia patients. And methotrexate is actually the chemotherapy that high doses of methotrexate are used, as well as in high doses intravenously as well. This methotrexate has been found to cause learning problems in these individuals, as well as radiation therapy to the brain, which is also directly related to the dose that you get, as well as, and as you know, as in total body irradiation, there is also radiation to the brain that can cause memory problems and short-term memory problems and other sorts of disabilities as well. When we think about preparatory regimens for bone marrow transplant, As I mentioned just a minute ago, TBI, or total body irradiation, is something that needs to be taken into consideration. And so if an individual's already had cranial radiation and then they get TBI on top of it, as you can imagine, this is really beginning to complicate the problem because you've just added more onto something that was already causing problems. Normally, TBI is not given at such high doses, but the fractionation dose and the scheduling is much more intense, and so we can also see some problems from that. And once again, age at transplant, younger age when the brain is still developing, is also of particular concern in this population. And also, most preparatory regimens for bone marrow transplant also have high doses of chemotherapy, and many of these are associated with neurotoxicity. And some of the chemotherapy culprits, so to speak, in this include busulfane, thiotepa, as well as Filleland, are three of the drugs that are often used in high doses in these preparatory regimens and can cause potential problems. Type of transplant also needs to be considered. For most autologous transplants, there's very limited research that's been done on this to date. But there is a really strong suggestion that there is no additional significant neurocognitive problems with these autologous transplants. Allogeneic transplants, however, there have been indications, particularly in individuals who have an unmatched related donor. an unrelated matched donor. The type of preparatory regimen, the age at the time of transplant, and in particular graft versus host disease, especially if it directly affects the central nervous system, can cause particular problems, or other bone marrow transplant related complications which can cause an individual to possibly be in isolation longer, have more loss of school time, that sort of thing, can also cause more particular problems in the allogeneic transplants. Other risk factors that we should consider, I've mentioned a couple times age at transplant, and really what we found is that the higher risk is mostly in individuals who are under age of 3, once again thinking about how the brain develops at a young age, seems to have the most problems, especially with verbal IQ and overall IQ. But really what we have found mostly with these bone marrow transplant studies is that the neurocognitive status prior to transplant is the thing that is most indicative of what the neurocognitive status will be post-transplant. It's really the strongest predictor. And what we have found is that the neurocognitive function is, if you evaluate somebody pre-transplant and compare it to 1 year post-transplant, you find that the neurocognitive function is actually quite impaired at that time. But often it tends to stabilize by the second year post-transplant. And a lot of this thought is that, once again, all the complications and the stressors, both social and physical stressors that go on in that first year, really cause problems, but then it goes back to stabilize. And I think we can kind of show this in particular with this slide. Sean Phipps, who's at the St. Jude's, had a very good article that was put out a couple years ago. And what this slide is showing is that on the y-axis, or on the left-hand side, what you see is the estimated intelligence quotient, or the estimated IQ level. And what we're looking at is at different age groups. And so 0 is their evaluation prior to transplant, and then they also had an evaluation at 1 year, at 3 years, and at 5 years. And what we see is that for the individuals who are 12 plus, which is the yellow line, that they pre-transplant they might be a little low, but they go up at year 1 and they tend to stabilize over time. So that once again indicates that since the brain's already been developed, there's really not a lot of problems going on. But the other thing I want to focus on is that the age group under 3, which is the dark blue line, starts fairly high pre-transplant. And then continues to go down in year 1 and year 3, but then once again tends to stabilize at that point moving forward. And I think that kind of gives you an idea of some of the possibilities of what's going on by age. And lastly, I just want to throw some things out for consideration. First is that there are very limited studies in this population, and most of them are limited to cancer patients, and we really need to do more to follow up larger groups over longer periods of time, especially transplant patients who are not with the original diagnosis of cancer. And also we need to start considering other factors. such as isolation due to long stays in hospital, but also socioeconomic factors, nutrition at a young age, that sort of thing. So what is the actual functioning at the time of transplant or at the time of cancer diagnosis, and how can we improve that as it moves along as well? And lastly, to remember that the neurocognitive effects may not be detected until many years after transplant. What we're finding is that a lot of these individuals haven't been followed up long enough, so we really don't, except for this Phipps article that I just showed you that follow people up to 5 years, there are very few studies that follow them 5, 10, 15 years, and I think we really do need to start to consider following these more longer term to find out what's going on, especially these young kids when they're 10 and 15 and 20 and how they do for the rest of their life. So I'm going to turn this over to Jordan at this time, and I'll answer questions at the end. Thank you.
So I'm going to talk about the specific learning problems that we might see in survivors of BMT. How many people today are parents or caregivers of school-age kids? Raise your hands. Okay. And how many of your kids attend school in Georgia? Anybody? Okay. Several. All right. So some of the things that I'll talk about towards the end are Georgia-specific, but there's also some resources that you can look at nationwide, too. So the things that I'm going to cover today, I'm going to talk about learning disorders, speech-language disorders, ADHD, cognitive disorder, NOS, and intellectual disability. So these are the things that would be that we see most commonly among cancer survivors and BMT survivors. Is that, you know, for these issues, these would be the things that would get you eligibility for some special services in the school systems. So with learning disorders, what we know is that the children are typically of average intelligence to above average intelligence. They just have a deficit in one area of their learning. So this would be, a child that does really well in, reading, art, but then has specifically struggles in math, or vice versa. Is an AB student across everything, but then significantly gets D's and F's in reading. So it's really pinpointed to one area of their academics. And something that's important to remember about our survivors is that a learning disorder can't be because of any of these other issues. So it's not due to low intelligence or sensory problems. So, for example, if you think about the risk factors for having hearing loss or vision problems, those might put you at risk for a learning disorder, but it really wouldn't be a true learning disorder because it was related to your medical treatment. And also environmental issues are important to think about, too. If you're in second grade and you're having a really hard time reading, but you spent all of first grade on a BMT unit and not in the classroom, then you don't have a reading disorder. That's really due to an environmental issue and can be something that with some special help, hopefully you'll be able to catch up with your peers. So the specific learning disorders that are in the DSM that can be diagnosed are a reading disorder, a mathematics disorder, the disorder of written expression, which the first two are pretty self-explanatory, but the disorder of written expression is when you have significant problems with writing, with organizing your writing. So we usually see that a little bit later on because, children aren't required to, write and organize information until later in elementary school. So we're thinking about kids that have problems brainstorming for a story and then putting their thoughts and ideas down in an organized fashion. And that can really cause a lot of problems, especially into middle school and high school, when a lot of your subjects require writing skills. And lastly, learning disorder NOS, which in the DSM we like to use not otherwise specified. It's our catch-all category for things that we can't classify any other way. But one example of this would be a nonverbal learning disability, so children that have a lot of problems interpreting information from graphs, have trouble with the visual spatial relationships, and that would affect learning in areas of math and science, but wouldn't necessarily be a mathematics disorder because they have a strong grasp of arithmetic and math skills. So another area that would qualify you for eligibility for special services in school would be a speech-language disorder. And there's 4 different types of those. The expressive language disorder is when you have problems putting your thoughts into words, so that the information is there, what you want to express is there. You just have a really hard time putting your thoughts and feelings into words and expressing those either in writing or in your speech. A mixed receptive expressive language disorder means you have those same expressive problems, but you also have difficulty understanding speech and language. So there's a comprehension issue as well as problems expressing your thoughts and words. There's phonological disorder, which means you have a really hard time understanding what the sounds of words mean. So some examples of that might be, having a hard time with your articulation or the way that you say words. Lisps, stuttering, those types of issues would fall under a phonological disorder. Then again, we have learning disorder NOS. So if you're having other speech-language problems that are causing impairment, they could be diagnosed under this NOS category. So ADHD. There are 3 main components of ADHD that we see. The first one is problems with inattention. So you can't focus. You have trouble organizing. These are kids whose backpack is a mess, who can't get the books that they need from school to home to do their homework. They get very distracted easily in the classroom and at home trying to do homework. Some forgetfulness. Because if you have trouble paying attention, then of course you aren't going to remember. That makes sense because it's not really getting in. You're not really processing that information. And we also see an avoidance of work. For kids that struggle with ADHD, sustained attention is just so much more effortful for them than it is for their peers. And so they just don't like it. And they will try normally to avoid things that are very, very effortful for them. There's also the hyperactivity piece. So problems staying still, quiet, they're on the go, kind of bouncing off the walls, really talkative. There's impulsivity. So having problems not interrupting, having problems waiting their turn. This can get in the way of developing friendship skills. And also difficulties with emotional control. So they experience much more hot emotions, hard time controlling frustration, and then a hard time calming down once they're upset. And so what we know is that there is ADHD combined type, which is all 3 of these issues together. And then there's also the inattentive type, which really is just the first category of inattention. And generally, for kids that weren't predisposed to have ADHD prior to transplant, it's the inattentive type that we see most often because the type of treatment they received is more likely to affect the parts of the brain that are dealing with attention versus these other 2 parts. And what's unfortunate about it is that the inattentive type normally gets missed because these are the kids that aren't behavior problems in the school system. So oftentimes they will continue on in school really struggling but not have the correct diagnosis or access to services that they need. And something that's important about attention is that attention is something that affects learning more globally. It's not going to affect just one area of your learning. And the reason for that is, like I said before, you have to be able to focus to get the information in your short-term memory. And if you don't get it in your short-term memory, it's never going to be transferred over to your long-term memory. So attention is going to impact everything from mathematics to reading to spelling. And there may be, your child may have problems with inattention and do better in some courses because of their natural abilities and talents, but it really does, what we see, sort of impact learning in a very global way. Cognitive disorder NOS is another important area that oftentimes gets missed. So it's a relative weakness in one of their cognitive functioning areas. And this is presumed to be directly related to their medical treatment.
What is that?
Not otherwise specified. Yeah. And what it does is it will lead to impairment in their functioning. And so some examples of this would include problems with visual discrimination. So problems being able to tell one shape from another shape in very specific ways. So that might cause problems with science, geometry, and it can also cause some difficulties in reading as well, depending on how significant the deficit is. So being able to tell one letter from another in a quick, effortful fashion. Problems with sensory integration. So having difficulty, integrating information from multiple domains. So reading and hearing, having one be more effortful than the other. Having problems organizing information. So if you can't organize information, it's very difficult to retrieve it. So if you think about sort of your kitchen drawer and how that's organized and how difficult it might be to find what you're looking for in there versus a very organized file cabinet. Children that have problems with organizing information, they're very bright. The information is in there. It's just very hard for them to access it because it's not in an orderly fashion. Problems with long-term or short-term memory, and difficulties with processing speed. So if you have difficulties with processing speed, it's difficult to get work done on time. It's harder to complete tests in the time that they're allotted. It makes homework time in the afternoon go much, much longer. There's also intellectual disability. So this would be significantly below average intellectual functioning, as well as problems in your self-care abilities. What we know about intelligence, or IQ, is that average is 100. And so children that have intellectual disabilities, their intelligence is much lower than the average IQ of 100. So you can see the different classification levels. There's mild, moderate, severe, and profound. And sort of your access to services in the school system and what type of classroom setting is best for your child would be based on how well they're going to be able to learn in terms of their intellectual functioning. So classrooms are generally set up targeted towards your child's optimum intelligence. So talk a little bit about testing. How many people have undergone the testing process with their child? Okay. In the school systems, raise your hand. Okay, private. Okay. So what to expect from a neuropsychological evaluation, which is generally done privately, normally at your child's hospital. That's the type of evaluations that I do for the Cancer Survivor Program at Children's Healthcare of Atlanta. What to expect is you're going to have, the psychologist is going to do a very thorough record review, a medical record review, to look specifically at what type of treatment your child received and how that might impact their functioning, and design the tests to specifically look for those problems. They'll also do an interview with you beforehand and spend some time talking very openly about what types of issues you're experiencing and what you see your child struggling with. And then they'll have you fill out rating forms. And then the day of testing, it's usually at least a half a day, if not more, and your child will do a lot of different tests, verbal and paper and pencil tests, to just understand their different types of thinking abilities, as I talked about before. We'll look afterwards. You'll get a written report. Ideally, you would have an opportunity to sit down with the psychologist, and they will go over step by step with you your child's performance and give you recommendations, something that you can take to the school to discuss the options on how your child can best learn. What we look at in a neuropsychological evaluation is intelligence, the intention of concentration, executive functioning, which is that organization piece that I talked about earlier, their memory and ability to learn new material, their language abilities, visual understanding and motor functioning, their academic achievement, or how well they're able to do in different subject domains like math, science, reading, and their social emotional functioning. And so this is a very comprehensive evaluation that takes into account all of their medical treatment. And these, like I said, these are normally done privately. The schools do an excellent job of a psychoeducational evaluation, which is different. It normally just looks at intelligence some learning, language, and academic achievement. So if your child really has a learning disability, a school evaluation might be perfectly fine. If your child is having a different struggles, you might need a neuropsychological evaluation that really takes into account the medical piece and looks at different domains. So in terms of the process for school assistance, to start the process, the first thing that you would need to do is to submit a written request to either your student's teacher, the principal, or the school counselor, and request a student support team meeting. And that would be a meeting where they talk about your child. You would be invited to attend, and you could discuss what the options are. You would also, I would suggest that you ask for testing at that point, or either provide testing that you've received from the community to talk with them and take that to the meeting. The reason that you would do the testing would be to determine their eligibility. And there's two types of services that kids are generally eligible for in the school system. One is accommodations, and that's a 504 plan, versus special education instruction services, and that's an IEP or an individualized education plan. And these are both federal laws, so these are terms that are the same across the country. An 504 accommodation plan really gives your child just that, accommodations. So examples would be extra time on testing, maybe a small group environment for testing. It wouldn't change the instruction that your child receives at all. It just would provide them with some extra tools that they need in order to be successful. This individualized education plan does change instruction a little bit. It offers them extra instructional support, whether that is included in their regular classroom environment and someone else comes in to help support them, another teacher or paraprofessional, or they go to a specialized classroom environment, a small group instruction for certain courses. So just some tips, what to do if you're starting the process for school assistance. If at all possible, attend all the meetings in person, just so that you know exactly what's going on in the school. You are the expert on your child, and so you need to be there to advocate for them and help the school understand what the issues you see going on with your child are, and to get the information from them and understand what issues they see going on in the classroom. Come prepared to meetings. Write a list of questions or write a list of things that you want to communicate to the teacher, because I think a lot of times in meetings we all kind of get caught up in what's being talked about, and then you go home and you think of questions or things you wish you had shared. You can provide an independent educational evaluation, so one of those neuropsych evaluations, or you can request an independent evaluation from the school. You can also seek out some advice and some resources. Here in Georgia, we have Parent to Parent of Georgia, which is an excellent resource. It is state funded, and it's run by parent volunteers. And all the parents have children with either exceptional learning disabilities or physical disabilities. And so they know this process, and they can help advocate for you within the school system. They also offer parent support and just tips and resources. There's also Parent to Parent. The Georgia chapter is Parent to Parent of Georgia, but it's also a national organization. And so you can look up on the national website to see if they have a chapter in your state. There's also this. They provide advocates for parents. Mm-hmm. And it's free. They provide free advocates because it's a volunteer services from other parents. And they can kind of talk you through what you need. I'm not sure about how they are in other states, but the one in Georgia is excellent. I've spent a lot of time on the phone with the people there, and they're great. My other recommended website, which is an excellent resource, is this LD Online. And it's not just for learning disabilities. It has information about ADHD. It has information about physical disabilities. It has information about what assistive technologies might be available. So it's a really excellent website that's very comprehensive and well done. It's also a good idea to just rally support from your healthcare providers and your mental health professionals that your child works with. a lot of times the school might be resistant, and so you might need some advocacy services or letters from your medical team. Question?
If I might just add a couple of things to what she was saying about requesting school services. And I don't know if they did provide, there was supposed to be a model letter that I had written. I don't know if they provided it or not. But some of the things you might want to make sure that you put into a letter, and this is based on federal law, okay, that all states have to comply with the federal law. And that in your request for evaluation, that you have a suspicion of a disability and that it's impacting your child's learning. You can't just ask, I mean, you can ask for, I want to know how smart my kid is, and they won't. They're not obligated to give that kind of testing. So you have to specify that, my child's having some problems on learning how to read, and I think it's because of a disability. Okay, it's not because I got a bad teacher, that there's something that's not right with my kid. Okay, so these are important differentiations. Yeah. That it's impacting the child's learning. Just make sure that, I don't want to give you a formula because everybody, but those are the things that need to be in it, and that as far as access to IEPs and meetings, a lot of times parents don't find the time that the school has convenient for them for whatever reason. You can request that the meeting be held at a time that's convenient for both of you. I mean, you really can't ask for a meeting at 7 o'clock on Sunday morning, but you could at a mutually agreed upon time. It could be after school. It could be, at a time where you could get in there, as long as it's a reasonable request. 2 o'clock in the morning on Thursday is not, that's not going to work. And also the independent evaluations, you have to look at your state laws, but there are procedures to ask for that. You can't, once more, you can't just walk in with an independent, I mean, most schools will take an independent evaluation and use it, but you can't just go to the school and say, I want an independent evaluation. They're not required to give it to you unless you meet certain criteria. But so there are all kinds of, little idiosyncrasies which your advocacy group that you were talking about can really help you with, so you do it right. But you have the right to ask for a lot of things under federal law, and for the school to give you help. In different school districts, same all over the country. I just worked in New York City all winter. From one school to the next, see a whole different way of operating depending on the principal and whoever's in charge of the special ed program. So anyway, I wanted to add that after that was it. Questions?
Where's the list?
The test that you would use, the names of the tests would be different based on what the issues that your child is undergoing at the time. And it's also based on what tests they've had. If they've had something in the schools recently, I would choose a different test battery because there's something we call practice effects. So if they just had one specific type of IQ test, I would give a different IQ test. And so it's the battery that the child would undergo would be very specialized for your child and their needs.
Does insurance pay very well for it here in Georgia?
It depends on your type of insurance. But generally, testing is the most easy thing to be reimbursed by your insurance in terms of mental health. It's much easier to get reimbursed for testing up to a certain number of units as opposed to therapy.
The other variable with that is the age of the student. The names change.
Because in Tennessee,
ideally, the best time to do a baseline assessment would be, prior to diagnosis, because once your child is already undergoing treatment or is in the hospital, their performance is going to be impacted. So they're not going to do as well as they normally would. We usually like to wait a year after treatment is completed to give them a chance to recover and just for fatigue effects so that they're able to show and to do their best work. I think what you would get right now would be an assessment as to whether or not he's having those inattentive problems. At age 6, it's usually too early to diagnose any type of learning disorder because they haven't gotten enough instruction to really know whether or not it's a true learning disability. So what we'd be able to tell you at age 6 would be more about what his intelligence is, and also if he's having problems with inattention or hyperactivity that are going to impair his learning. We could also look at memory as well, and ability for new learning. But as far as academics go, we wouldn't be able to really tell you whether or not he had a reading disorder yet.
Any more than you would any 6-year-old. I completely agree.
Right.
I just met her this morning, and I agree with everything she's saying so far. So that I don't know what that means. But really, testing any 6-year-old, you're going to get different test scores a year later and at 8. I would talk with the teacher and compare them to how other 6-year-olds are doing, because they're all over the board. I mean, there's kids that can come in and they can read you the school handbook, and there are other kids who come in and they don't know what the letters B looks like. I mean, they're all over the place, and that's not uncommon.
That sounds like attention issues.
Yeah.
I have a list of questions, but okay. You went over all the chemos that can affect neurocognitive status. Do you see problems with high-dose steroids, dexamethasone for 6 months? Or do steroids cause problems in neurocognitive functioning?
We have not identified that at all as far as causing problems. The fact that they're in the hospital so long or, just having treatment would probably be the culprit more than the steroids. I have not seen anything that's related to steroids.
Okay.
I've seen something that if you had high-dose steroids that were intrathecal, then that might cause problems. So if it was delivered directly into the central nervous system, then that can cause neurocognitive issues. But high-dose oral steroids, there's no evidence in the literature that contributes.
Do you have any suspicions? I mean, it might not be in the literature, but are there suspicions that...
My suspicion would be that it would impact learning indirectly, that it wouldn't be related to their cognitive abilities, but that I'm sure that if any of you have ever been on a steroid regimen, you know what that feels like in terms of frustration tolerance and emotional control. So being on a regimen like that for 6 months, I would think would impair your emotional or psychosocial efforts and abilities to learn, but not in terms of permanent, any sort of cognitive damage.
Having lived with a woman who took steroids for a year, the impact on the caregiver is probably just as great as it is on the person who took it. So.
Okay. Do you have any scholarly articles or that we can provide to teachers to show them what to look for? Or
showing teachers something and getting them to read it and then getting to absorb it are three different.
Well, they're asking
for
materials.
3 different issues. So
the teachers want something on paper so that they can read and find out what's going on.
And they usually like it color coded too. So.
Can we talk specifically about? I'm assuming you're talking about a child. Is that your child?
Yeah.
Did they have either leukemia or a brain tumor?
An immune disorder.
Immune disorder. So they didn't have cancer beforehand?
No.
There's such little literature out there. And the Phipps article that I just put out there is probably the best article out there right now. But if you read it, it pretty much says that there's not a whole lot going on. But it's very patient specific. So if you were trying to convince, but it actually goes into a lot of detail about verbal IQ going up and down, overall IQ going up and down, that sort of thing. So it might be worth looking at to see whether or not you can relate it to your child.
Okay.
But other than that, there's really unfortunately very little out there that I know of.
All right. Okay, next. Now, when these neuropsych tests are given, we've already had our neuropsych and nothing showed up, but I know clearly there's something wrong. When it's given, there is a facilitator pointing to every question and making sure that he's following along. He was 6 at the time. Inattention doesn't show up that way if somebody's keeping him on task for 6 hours straight. Does inattention normally show up even though you've got somebody keeping him on task, like telling him what to do?
So that's something that I have seen a lot. And so I will specifically write in my report if for some reason, the self-rating forms that you would complete and that his teacher would complete about his ability to attend in the home setting or in the school setting, I will specifically write, they did very well under this one-to-one special circumstance. And so that tells me that they do have the ability to attend and that with accommodations that make things more one-to-one or interactive, they would do quite well. But that, left kind of to their own devices, nothing happens. And I do usually, if that's something about, the neuropsych battery, I don't like to say specifically what we normally give because it's a little bit fluid, and I'll change it based on how the child is doing during the day. So if I were to see that problem, then I would have the child do a task where they have to do something independently to measure their attention. It's a 15-minute computerized task. So if they do well all day, and then I give them this test at the end where they have to sit and attend and do this very boring task, I always tell them that it's awful because they have to sit and push a button on the screen. And generally that's a way that I could capture problems with independent attention.
Yeah.
Did you get all your questions? I want to make sure everybody has a chance to ask questions.
One more.
Okay.
How do you tell the difference between just plain old flightiness, an absent-minded kid, versus inattention disorder? Something it's hard to tell the difference between what's behavioral and what's medical.
Agreed. So something that I will generally look for is whether or not there's any family history of ADHD, and also what their specific treatment regimen was. So there are specific things that would make a child more likely to have attention problems than other treatments. So those are two of the main things that I use to base my decision on whether it's medically related or not.
Yeah. Your child's medical condition is only part of who he is, and it isn't
Right.
he is who he is. And so all those other things come into a factor too. And if your school's doing good evaluation, they're going to look at the whole kid and not just that part. I don't mean this to sound derogatory towards teachers if I say this, but teachers are real specific, and they like to have real specific things that they can work on. And I think it's our job, as I found it's my job as a parent, as administrator, to help them look at the whole package, because they are so focused right now on kids passing tests, because to look at the whole kid, they need help doing that. And that, I think, is a part of it. And the testing that you're talking about can be very good, but it doesn't always catch ADHD. There's all kinds of tools that are made for teachers, for parents, for kids, and you can start naming them off, but they're only as good as the person who's administering and observing it, because a whole lot of it is, a lot of it you can measure, some of it you have to observe, and so you have to look at the whole package. So I don't know if you.
Well, I also have a list of questions, but well, I know where my kid got her ADD. That was straight from me, but her treatment and her course of therapy, et cetera, have really sort of exaggerated that. But and I'm trying to organize what we're experiencing, and for me, that's identifying what the problems are, which you're showing us, and we've done with neuropsych testing, and finding accommodation through the schools, which took us 1.5 years. But I'm also looking for remediation, coaching, and I just wondered if you had any comments about that, and specifically with regards to that, I'm looking for help for issues around friendship skills, because she is really inattentive and globally. She's 14, but one of the things that troubles me that the school doesn't really address is like when her friends come up, she's in middle school, so they're just standing next to her, and she's completely unaware. She's in her own little world, or she's aware that they're there, but the social cues of like saying, hi, how you doing, or talking about something, it's not happening. So I don't know whether to get her dear friends together and just talk to them and say, she needs your help in this way. But that's kind of burdening them, even though they've been on the journey with her for a long time. So just wondering if you had some comments about that.
I would not do that, only because I think as a 14-year-old,
Yes.
she might find that to be mortifying. I would have been mortified at 14 if my mom had set my friends down and asked them to treat me in a special way. But I agree that the peer friendship skills can be a real issue. And so I'm not sure where you guys are located. But
Athens.
Athens. Oh, okay. See me afterwards. Okay. I have lots of referrals.
And then I have another question, which actually a couple of parents and I talked last night, and that is the temptation we of all had to take our kids and put them in private schools, and then found that wasn't the answer either. That's one question, and I wanted to hear about that. And the other one was, in the public schools, why are the schools so resistant or take so long to get to the 504 and the IEP? I mean, it took us a year and a half with all those things done and all the documentation and et cetera.
The private school issue is related to the fact that private schools aren't required to follow the federal laws for the individualized education plans and the 504 plans. Because they're private, they're able to do what they want. So public schools are the only schools that you have written legal rights for specialized services. And in terms of the timeline, I think different schools are just burdened. And there's a new initiative called Response to Intervention. So sometimes kids, for several weeks, up to several months, are having some changes in the classroom environment before the school is willing to move on to do a 504 or an IEP plan. So that can sometimes delay the process. But I think it's unfortunate in some ways, but it is a good-hearted initiative in other ways, because it really is trying to see if your child can benefit from the least restrictive environment. So we're not wanting to put your child in a special classroom or pull them out if there's certain things that their teachers could just tweak to help them learn.
The problem with getting to me to be a moderator is I can't not answer some of these questions. And I agree with what she's saying. And I just tweaked the language a little bit because the response to intervention movement is based on really parent-led advocacy for full inclusion of all kids in general education. And so that just providing services through special education is not a place, but it's a service, and it should be done in the least restrictive environment. That's a parent-led initiative that removing kids from the general ed setting has not proven to be effective, and parents understand that. And just for some of the reasons you were just talking about with your daughter socially, for one thing. Pulling them apart and saying that they're somehow different, and that serving them in a different place is going to help them. Now, from an administrative standpoint, there are definitely, and it's what I look at it, there are definitely some kids who benefit from separate settings and from separate classrooms, et cetera. But in general, and what she's saying about schools being overburdened, and lots of different referrals and things are there, and the RTI movement, the response to intervention movement, is there. They're trying to keep kids out of special programs, but to be able to provide for them within the general ed setting. Some of that's funding based, where the money flows, and so it's a very, very complicated manner. But the biggest thing about what happens in the schools is based down to really the building principal and the administration within your school district. And I just spent 9 weeks in New York City, which is the largest school district in the world. And the difference between building to building is enormous, and it could be 2 blocks away. It's if you get this, go through your building, and that's where your real chance of impacting change is. All this other stuff and the laws and all that stuff are important, but it's really the guy who's running there, the person who's running the building. So anyway, like I said, it's dangerous to get me to be a moderator. Another question.
One thing I think is definitely, it sounds like you need some advocacy help with the school system. Where are you guys located? Okay. So I would start with that Parent to Parent of Georgia website, and you can even call them. The phone number is on the website, just to to start the advocacy process with the schools. Because if she's not in the environment, the learning environment that she wants to be in, and she's not in the environment that you want her to be in, then I think that is a conversation that needs to happen with the schools very soon.
Like I said.
The other thing is part of the process, is talking about the recommendations. Sometimes, we, in the feedback sessions, depending on the child or the teen's age, I will have them come or not come. But that would be a time when you can sit down and kind of talk about a willingness of, what you want to do and what you don't want to do, what you're comfortable with and what you think wouldn't work for you. I think that that's an okay conversation to have with the person doing your evaluation, and they can also tell you how they feel and why they think that would work.
And ask them about transition planning and what their and who the transition planning person is. That's right. And there should be somebody in your school by federal law, okay, who's responsible for transition from school to the rest of your life. And
have you started the VOC rehab process yet? Not yet. Okay.
Okay. All right, we need to wrap this up. Are there any more quick? Yes, ma'am.
We spend, the computer test that we do is usually only 15 minutes of the whole day. And so part of what we do beforehand is an interview. It's what we call a diagnostic interview, where we sit down generally with the parents. But for somebody that would be your age, I would like to have some time to spend with you, talking with you about what you see your needs and issues being. If you were 6 years old, I wouldn't invite you to that interview. But at 17, I think that you would have a lot of thoughtful things to contribute. And
I think that most professionals would love to hear from you instead of the usual answer, which you get from a 17-year-old, which is, I don't know. Okay. Okay. All right. Any other questions? We'll hang around here for a few minutes afterwards. Your next session starts in 15 minutes, so give yourself time to do what you need to do and get to there. And do we have session evaluations? I think so. So anyway, thank you very much.